Thank you all for being here. Welcome to what I think is going to be a spectacular day. My name is Ashish. I'm the faculty director of the Harvard Global Health Institute and a professor at the Harvard T.H. Chan School of Public Health. We come together at events like this often to try to tackle complicated problems. The last time we were here, we were discussing misinformation and how do we counter it in the context of public health. We've had discussions about how do we tackle the Ebola outbreak. These are really important issues and good reasons for us to get together. Today's a little different. And it's a little different because we're going to do something that I think we just don't do often enough. And that's to look back and to actually celebrate what has been, I think, an unmitigated success. And that is the PEPFAR program. PEPFAR has saved, depending on how you count, 17 to 18 million lives. It has prevented a large number, and you're going to hear all these statistics coming up, of maternal-child transmissions. It has, I believe, really changed the face of HIV and AIDS across Africa and in many ways around the globe. So it's an extraordinary moment. It's been 15 years, and when we, with our partners at the Petrie-Flom Center, at CFAR, you can see all the folks who've been involved in this, the Center for Health Law and Policy Innovation, when we sat down and talked about PEPFAR, we thought it was really important to mark this event, to mark the 15th anniversary. And because it's been a very collaborative effort across the university, we have a few people who are going to come up and say some opening remarks. And each of them, I think, has a very important perspective. It's also the beginning of Worldwide Week, and this is something that comes out of the Office of the Vice Provost for International Affairs. And it's a week to celebrate, but to also acknowledge Harvard's engagement in the world. And this is the kickoff event, and no one better to help us get it started than the person who's been the mastermind of Worldwide Week, Mark Elliott, who's the Schwartz Professor of Chinese and Inner Asian Studies, and he is the Vice Provost for International Affairs. I often refer to him as the Secretary of State of Harvard. Mark, thank you for welcoming us.
Thank you so much, Ashish. Thank you. Good morning, everybody. Good morning and welcome. Welcome especially to guests from outside campus and particularly from the number of those I met from the NIH in Washington, or just outside Washington, which has been such a key partner here. So we're convening today to celebrate and reflect on the accomplishments of PEPFAR, the President's Emergency Plan for AIDS Relief. This, of course, as everybody here knows, a truly historic effort that has played a major role in changing the course of the global AIDS epidemic by making drugs, ART drugs especially, available around the world, saving millions of lives, as my colleague Ashish has just mentioned, and bringing infection rates down from their peak in 2005. Today's event, from where I stand as the chief international officer, if you will, of the university, is a powerful example of Harvard's engagement in the world and the ways in which Harvard can help to act to help improve the world, make it a better place. I'm especially excited and grateful to the Harvard Global Health Institute for scheduling this at the very beginning of Worldwide Week. This is the third year that we are doing this, an effort by my office to try and shine a spotlight on all the different ways that Harvard is present in the world and the ways that the world is present at Harvard, which is really sums up the mission of my office. It's a remarkable breadth of engagement crossing every single school, many different centers and institutes, several dozen, in fact, the last time I tried to count them all. And the HCHI has always been a very strong supporter. We aim for one marquee event every day of Worldwide Week, and I'm pretty sure every year we've done this, whether it's been in Longwood or whether it's been on this side, the Global Health Institute has been there to help support these efforts. So thank you very much, Ashish, and thanks to everybody in HCHI for helping to make this happen. Now, less than 20 years ago, when the PEPFAR program was first announced, there were an estimated 36 million people throughout the world living with HIV/AIDS. But without proper access to treatment and resources, AIDS was a death sentence, right? Novel antiretroviral drugs were only available in high-income countries, whereas in low and even middle-income nations, mortality rates were extremely high. Harvard joined the PEPFAR effort from the beginning with a grant in 2004 from the government, a grant of $107 million to support Harvard research in this area. And as I believe Dean Williams will say a little bit more about that, I'll leave that for now. But at the time, that was certainly the largest research grant Harvard had ever received. And we endeavored to make good on the faith expressed in the university with this grant by using that to further our research efforts, which had already gotten underway at that time. And we saw this as a unique opportunity for collaboration between the government and ourselves, and we were very happy to be able to help implement the program. I myself, in my travels on behalf of the university, have witnessed in person some of the results of this amazing work. I'll point out just a couple of examples in Botswana, where the Botswana-Harvard partnership, led by the Harvard AIDS Initiative at the Chan School of Public Health, has made an enormous difference in many lives and dramatically reduced the rate of perinatal transmission of HIV. And also in South Africa, where the Regon Institute, in partnership with the University of KwaZulu-Natal, has formed the Africa Health Research Institute to carry out critical research in the prevention of HIV infection and to stimulate awareness among at-risk populations. And I traveled to Durban and to Bloemfontein to see exactly what this work looks like, what it consists of, and it's just truly impressive. For today, many Harvard institutions have come together to make this event possible, including, of course, the Harvard University Center for AIDS Research at GHI, the Petrie-Flom Center for Health Policy, Biotechnology, and Bioethics at the Harvard Law School, and thanks to the law school for giving us this beautiful space, and the Center for Health Law and Policy Innovation, also at Harvard Law School. It's really when Harvard comes together across disciplines and fields and collaborates across sectors and industries that our efforts to solve complex challenges become most meaningful and effective. And I'll end simply by expressing, on behalf of the university, congratulations to all the hardworking researchers, technicians, administrators, students, professors who have been part of this remarkable collaboration, helping Harvard to do its part in realizing the dream that animated PEPFAR 15 years ago, the dream of turning HIV/AIDS from a death sentence into a disease. Thanks very much, everybody, and good luck for the conference.
All right, thank you, Mark. So, as Mark alluded to, central to the effort, certainly central to Harvard's effort in this area, were the activities that happen at the School of Public Health. And you'll hear more about that later in the day from the PI of that effort. But the School of Public Health has been deeply engaged on these issues, not just from that grant, but from that time onwards. And so we really couldn't do this without having Dean Michelle Williams, who's a preeminent epidemiologist and a great leader of our school, to come and say a few opening remarks and provide some context about PEPFAR more generally, but also really about the school's engagement. So Michelle, thank you so much for being here.
Good morning, everyone. Thank you, Ashish, for that introduction, and Mark for your remarks. I would like to add to both Ashish and Mark's welcome. Welcome, and thank you for spending your precious time with us to celebrate this really remarkable public health program. And also for so many of you who've been involved in this and have been involved to the level of inspiring people to make this 15-year legacy of PEPFAR real. The President's Emergency Plan on AIDS Relief was initiated by the Bush administration in 2003, as you heard, and it's by far the largest single disease intervention in history. And it's fantastic to see so many key architects and implementers of this groundbreaking effort right here in this room this morning. As many of you know, the Harvard T.H. Chan School of Public Health was a partner in PEPFAR from the very start. In 2004, a team led by Phyllis Kankey, and you will hear from her later today, became one of just 4 initial institutions chosen to pioneer the implementation of this novel program. Our long-established partnerships with the organizations working to combat AIDS on the ground in Tanzania, Botswana, and Nigeria had certainly given us the foundation upon which to build comprehensive approaches to tackling the epidemic. But they also drove a sense of urgency. Joining the PEPFAR effort felt like a natural response to a humanitarian and ethical crisis that was unfolding as HIV/AIDS continued to spread and to kill. Receiving the largest grant in Harvard's history at the time provided our school and university with an opportunity to partner with the administration across all of Harvard and to get life-saving treatments to those desperately in need, especially in countries with weaker healthcare infrastructure. And we also needed to temporarily expand our traditional activities in research, advising, and teaching. And this essentially led us to set up an implementation effort, such as overseeing patient care and building and operation drug distribution infrastructure that we had never had to do as an academic body before. We did this with a long-term goal of independence and sustainability in mind, by establishing nonprofits in each of the nation that would receive funding to do this work. We built an infrastructure for the countries to feel ownership from the start, and as it turns out, PEPFAR program as a whole ended up replicating its model with other country partners. Today at this gathering of many great minds that are here in this room, we will discuss what we all have learned in the past 15+ years of working as a major PEPFAR partner in PEPFAR-focused countries. By succeeding with PEPFAR's initial goal, which were providing millions of people with prevention, testing, and treatment options, we have collectively been able to make a tremendous difference. But we have also uncovered underlying issues that stand in the way of reducing new infections to zero and eradicating this disease once and for all. The HIV/AIDS epidemic, as you all know, is a complex challenge, and it can serve as an important example for everyone trying to solve intractable problems at a global health scale, both in where we succeeded and where we are hitting new roadblocks. Questions about treatment adherence, gender disparities, lack of trust in institutions and authorities, and of access to quality care are not unique to HIV/AIDS. They are actually essential to the many other major efforts that are ongoing and important to global health. Many in the larger Harvard community and the PEPFAR community are working on innovative, multidisciplinary approaches to address this next level of challenges. That is why I'm so very much looking forward and I'm grateful that we're having a conversation like this here today and tomorrow. This is an important time to collectively reflect, to share on our lessons learned, and to generate insights on how best to move forward. So thank you for your attention and thank you for your efforts on behalf of global health.
Thank you, Michelle. All right. Last but certainly not least is my friend Glenn Cohen, who is the director of the Petrie-Flom Center, a bioethicist and legal scholar extraordinaire. Glenn, thanks for being here.
Thank you very much. So first of all, thank you for coming to our space. I want to welcome you on behalf of myself, my center, the other center that's represented here, and especially our dean, John Manning. We're thrilled that you're here. So with my ethicist hat on, well, first of all, I should say a big thank you to 2 members of my staff, Caitlin Dowling, Chrissy Hutchinson-Jones, who are very, very helpful in putting this together. But I want to put my ethicist hat on and get you to think about a couple of issues. The first is the trade-offs between individual versus statistical lives. Individual lives, the lives we see, the lives we know we can help. Statistical lives, a much larger number of lives out there who perhaps don't even know they need our help now, and how that plays out in these debates. Do we have stronger duties to those we can identify than those who are statistical? I also want you to think about the amazing innovations we're going to talk about and the research design and the research ethics that were caused by them. That's with my ethicist hat on. With my lawyer hat on, which is a little bit more like the clouds than the sun, right? I want to do three things. First of all, I want to speak plainly. Second, I want to be a pragmatist. And third, I want to be a rule enforcer, because those are three things lawyers are known for. So first, to speak plainly. We are living in a period of rancid partisan division. So much so that to look at PEPFAR, which President Bush still regards as his shining achievement, the best thing he did in his term, is really this hopeful moment to think what we might be able to achieve even in this moment. Second, the pragmatics. Most pragmatic thing I can tell you is that the bathrooms are over there and to the right. You know, you think, you don't need this in the introduction, but midway through the day you might be wondering and you're happy I told you about it. Last, rule enforcer. We have a microphone, we have a queue, people can ask questions, but I want to emphasize that they ought to be questions, not soliloquies. If after the first 20 words there's no question mark, chances are it's unlikely to be a question. So when you're asking a question, make sure it is a question. Okay. With those three bits of lawyerly wisdom, I will welcome you and I'll turn it over to our first speaker. Thank you very much.
Wow. All right. Thank you, Glenn, and thank you for that very pragmatic. I should have told you guys about the bathroom, so thank you, Glenn, for bailing me out. I am going to turn it over to my partner in crime, Ingrid Katz, who is going to MC the rest of the day for us. Ingrid is an infectious disease doctor at Brigham and Women's Hospital, an HIV researcher who's been working in South Africa for a decade. And you know, when Dean Williams talked about the roadblocks and challenges, one of them is that there is a group of people who, for a variety of very complex reasons, have not availed themselves of the miracles of modern medicine when it comes to HIV. And understanding why that is and what we can do to help people get into treatment is extraordinarily difficult work. And that has been at the heart of Ingrid's work over the last 10 years. And so she's a phenomenal scholar who really takes on the hardest topics. But this morning, she is going to lead us on and very quickly get you to our first keynote speaker, Tony Fauci. But let me turn it over to Ingrid, who's going to lead us on for the rest of the day. Ingrid, thank you.
Thank you so much, Ashish, and thank you all. I'm so thrilled to see everybody here today. We have been working tirelessly with our colleagues for the last 6 months, and it's just wonderful to see this full house. As Ashish said, I'm Ingrid Katz. I'm the Associate Faculty Director here at the Harvard Global Health Institute. And I just wanted to do a few brief remarks before we come to our first keynote speaker. As a clinician researcher, as many of you are in this room, I've really had the privilege of witnessing firsthand the impact of PEPFAR in South Africa. And I've also seen the struggles of people who continue to face discrimination and stigma. And it really shows that PEPFAR is nothing short of miraculous to get so many people on treatment despite all of the challenges that have faced people and countries as they've moved through treating this epidemic. In this moment, as we come together, we're calling this a day of celebration, and we really want to acknowledge the tremendous work that's been done by PEPFAR and all of the people who have fed into this community. And so just to map out the arc of the day for you, we actually have a tremendous opportunity here to tell the full narrative of this arc. And we're going to start at the very beginning with our first keynote and take you all the way through the last 15 years to really speak to all of the chapters. So we have our wonderful keynote speakers, and then we have people who are working in PEPFAR-focused countries, both in the countries themselves and also here at Harvard. So we have a wonderful complementary group of people. I just want to also let you know, as many of you have heard, that there is tweeting that's happening today. If you are someone who tweets, feel free to tag us in. So without further ado, I'd like to kick off with Dr. Tony Fauci, who is a longtime friend of Harvard. He is, as all of you know, the head of NIAID. He's been there over the past 35 years, and really more than anyone else, has been instrumental in keeping science at the forefront of the government's epidemic response, and we couldn't be more thrilled to have you here today. Thank you.
Thank you very much, Ingrid and Ashish. It's really a pleasure and a privilege, actually, to be here with you this morning to kick off this very important symposium. And as Ingrid said, we're going to talk about the arc of PEPFAR. So I'm going to take you to the very, very beginning of before PEPFAR and then lead into PEPFAR so that I think you'll appreciate, particularly the younger people in the audience, what was going on back then that was important in triggering this. So if you'll allow me, I just want to go back a little bit before to give you my own personal perspective of where I was at the time and the kinds of things that I was thinking about that many other people were, and certain circumstances that allowed the evolution of what you're going to hear about. So I had been at the NIH already following my chief residency in medicine for about 9 years, from 1972 to 1981, when these two publications from MMWR appeared. The first in the June of 1981, some of you know that history, 5 men curiously all gay from Los Angeles who presented with an unusual pneumonia. I was the infectious disease doc at the NIH, so I had seen a lot of pneumocystis on the cancer ward as an infectious disease consultant. So I thought there was something strange here, but I just blew it off, to be quite honest with you, until 1 month later, in July of 1981, when another MMWR came out, now, curiously, 26 men, amazingly all gay men at the time, who presented not only from Los Angeles, but from San Francisco and New York City, not only with PCP, but also with this strange tumor called Kaposi sarcoma and other opportunistic infections. It was at that time when people ask me why I did this. I don't know. I'm trying to psychoanalyze myself, but I decided that I was going to stop what I was doing for the previous 9 years, which was really relatively successful. I was involved in studying autoimmune inflammatory diseases and the relationship between immunosuppression and infection. And I decided to start studying what was at the time these gay men who we were admitting to the NIH. My mentors actually thought that I was doing something foolish in interrupting the arc of my own personal career. And one of them, actually, who was a very close friend of mine, used the terminology, please don't give up your day job to do this. So I felt it was important for me to articulate why I was doing things that my mentors were telling me were untrue. Not untrue, but were foolish. So what I did is that, and this is the truth, I wrote a paper and I submitted it to the New England Journal of Medicine. One of the reviewers definitely said reject it because I was being too alarmist. So I submitted it to the Annals of Internal Medicine. So see, the date is June 1982. I wrote it in like November of 1981. And what I said in that was, because we do not know the cause of this syndrome, any assumption that the syndrome will remain restricted to a particular segment of society is an assumption without scientific basis. And that was at the time, I believe, that there were 159 reported cases to the CDC. So what happened then is that I devoted the next few years doing what some people in this room did. So here is a picture of me on our ward. This was, I believe, in December to January of 1981-82. At the time that many of you know, the life expectancy of individuals was about a year for a number of reasons. Obviously, we know what HIV can do, but they usually presented very late in the course of disease because this was a few years before we knew what the etiology was, so we obviously did not have a diagnostic test. So you only presented when you were clinically very ill, not when you thought you were infected. So during that period of time, I describe, and I could talk about that forever, kind of the dark years of my life and my career, because I went from treating people who were all getting better from these inflammatory diseases to patients, almost all of which did not survive. And then there was a ray of hope. In 1986, 1987 was the first and only placebo-controlled trial of a single drug, AZT, which, as you see here, the original data, placebo had 19 deaths, AZT 1. And from that time on, there was a progression over several years. We had a lot of hope back then, but some of us who understood what RNA viruses were realized that this was not going to last long, that a single drug for a highly mutational virus is very soon going to escape the therapeutic impact of that drug. But over the years, things got better and better. In 1987, it's very interesting. This is viral load and durability. We didn't even yet have sensitive assays for viral load. We were measuring P24s at the time. So the viral load went down a modest amount and then came back. In 1984, we went to 2 drugs. That's when lamivudine came in. It was lamivudine either with AZT or DDC or DDI. The viral load went down even more, but again, it was not durable. And it was only in that now iconic discovery in 1996 with the introduction of the protease inhibitors to the triple combination did we actually have virus that went below detectable level. Because at that time, the very sensitive tests were used and came in to our ability to use them regularly, and it was durable. So for the first time, we were seeing people who had a clinical turnaround that was durable. And this was presented at the Vancouver meeting in 1996 that ultimately eventuated into the 3 classic papers of triple combination that actually allowed people to essentially begin to even imagine the possibility that they may be able to lead normal lives. And the history of that, as you know, over the years, we have now more than 30 drugs that when used in combination of 3 and now most recently 2, can actually give durable control of virus. And on the right-hand part of the slide, we now have single tablets, as you know, which a single tablet containing 3 drugs once a day can actually do that. So what happened over a period of those years was going from what I told you early on with a life expectancy with advanced disease of about a year to the point today when any of us in this room, certainly in my own clinic, that we still have at the NIH that I still see patients on, if someone comes in who's in their mid-20s, recently infected with HIV, and you put them on a triple combination, you can look them in the eye and honestly say that if they take their medications, it is likely that they will live an additional 50 years, which would bring them almost to, but not quite, a normal life expectancy. And with that, the death rates in the United States went down dramatically, as you could see from this slide. In addition, the reduction in maternal-infant transmission, and now the beginning of the idea of PEPFAR starts. When I say idea, I don't mean anybody was thinking of PEPFAR, but the basis of how we went into it starts. Because now you know the very famous 076 study, which showed that if you gave pregnant women AZT for a considerable period of time in the 2nd or 3rd trimester, and during delivery, and for the baby for 6 weeks after, you dramatically diminish the mother-to-child transmission. That was great news. However, the conventional wisdom is that prevention of mother-to-child transmission regimen of AZT was too expensive and not feasible to be able to be implemented in sub-Saharan Africa and in other areas of the developing world. But then something happened that turned that around. We had the intrapartum and neonatal single-dose nevirapine, which compared in a study with AZT for the prevention of mother-to-child transmission in a study, a randomized study in Kampala, Uganda. And as it turned out, a single dose to the mother at the onset of labor and a dose within 72 hours of birth to the infant brought down the transmissibility to about 13% compared to a comparable AZT study, which brought it down to 25%. So if you did the math on that, there was the potential to prevent hundreds of thousands of infections in infants. And then we figured out, we, the field, that that would cost about $4. And so the issue of mother-to-child transmission in the developing world became something that was felt to be feasible by a lot of people. I'm not talking about me, I'm talking about people who were talking about, can we actually do that? So I'm going to show you, and I want you to concentrate on the dates of the papers that I'm showing you. So this is July of 1999. A year later, at a meeting of the International AIDS Society in Durban, South Africa, there was a upswell of activity about treatment access for the developing world. A lot of people began talking about that. Faith-based groups, individual groups, can we now get treatment to the developing world? Myself and others in this room, I'm sure, who had been to Africa multiple times, I took a number of trips to Africa. On one of them, I made a bunch of notes, and I went back and looked at the notes for this particular discussion. On one trip in April of 2001, I went and looked and went to my colleagues in Uganda, and I put these names down because these were some of the people that I had the opportunity to talk to. Some of you recognize the names, some of you are their colleagues. That was in April of 2001. Now, something happened a few months later that was a circumstance that was terrible, but that put me in a position to be able to have access to someone who was essentially the reason why we have PEPFAR. And that was the tragic events of September the 11th, 2000. Because juxtaposed with that was the anthrax attacks of 2001 October. Now, some of you may be saying, what is this guy talking about? Anthrax attacks at a PEPFAR meeting. Because what happened is that brought together the issue of, are we going to have a biodefense program? And at that point, I got to have considerable amount of interaction with President George W. Bush. And this is a picture of the announcement at the time of the beginning of the biodefense program, in which billions of dollars were invested. And as you can see in that picture, there's Tom Ridge, who was not yet the Secretary of the Department of Homeland Security. He was the Homeland Security advisor in the White House before he became Secretary. Julie Gerberdine was the CDC director at the time, and I was there because the president announced a $27 billion budget for NIH, including a $1.5 billion aimed at bioterrorism. So what we did is that we put together a biodefense research agenda and strategic plan. Okay, so now what's the connection of how that's leading into what I'm going to say? As part of that, a few months later, the president was going to make a trip, and did make a trip, to Pittsburgh to talk about this new computer system which can link into emergency rooms throughout the country to pick up subtle increases in disease that may be a covert bioterror attack. Having been the person involved in the biodefense issue, the president invited me to accompany him on Air Force One to go to Pittsburgh. On the way up there, I didn't have a chance to talk to him, but on the way back, he called me into the cabin. By the way, for those of you, this is much better than United, I got to tell you. On the way back, he called me into the stateroom, and we were chatting with him and D.A. Henderson and others, and he said, Tony, what scares you most about potential microbial threats that a terrorist might use? And I told him this would be the opportunity, because my mind was fixated much more on HIV than it was on bioterror. And I said, Mr. President, I worry more about the natural occurrence of an influenza pandemic, but importantly, the ongoing plague of HIV, than I do about a bioterror attack. And it was about that time that the president himself, and it isn't that I encouraged him to do that, he was thinking about that himself. So the credit goes without a doubt to the president's own feeling. And one of the things he has said and repeatedly said, and this is words that he's told me, he's told Mark, he's told a lot of people over the years, that we as a rich nation have a moral obligation to help those who do not have access to HIV treatment and care because they lack resources. So what he did was he sent in the spring of 2002 me and Tommy Thompson on a fact-finding mission to Africa to determine the feasibility of doing something. And we didn't know what something was. We visited a number of countries, and I had the opportunity to go to places that reminded me of what I was doing in the picture I showed you in 1981-82. where you had someone in front of you who was deathly ill and you could do nothing. But now it's 2002, and there are drugs available, and yet these individuals could do nothing. For those who had a few resources to get drugs, it became clear that in this case, this was a young woman who had drugs mostly from a philanthropic organization who went into the bush as shown here. And here I am with a bunch of children in a village, some of whom were actually infected. So the thought arose that if something, what would that something be? And the easiest thing to have done is perhaps we can propose to the president an issue of a program that was mother-to-child transmission prevention. Now, I can't go any further except to say that none of this would have really happened the way it did without an unusual relationship. And this might surprise you. This is a picture of my laboratory. And as you can see in that laboratory, there's somebody there that you actually recognize. And that's Mark Dybul. Mark, at the time, had gone through a fellowship in the lab, was an extraordinarily good researcher, an outstanding clinician, but had a burning desire to do something on a much, much broader scale. And it was fortunate for me, fortunate for the NIH, and certainly fortunate for the world that Mark was actually there and had a keen interest in that. And so we put together a program that was a mother-to-child transmission program. And on May 29th, 2002, I made a presentation to President Bush in the Roosevelt Room with a number of his senior staff and cabinet members there. And I show you this because it's kind of fun for me, actually. So there we were making the presentation. And something happened there that very few people know how it happened and what happened. But I made the presentation, and Tommy Thompson said, I want to now have Tony make this presentation. The president loved it. But what happened next was extraordinary. There was, I call, a friendly competition between USAID and HHS. Andrew Natsios was very upset because he said, we have a memorandum of understanding that anything that's health that's international is USAID and HHS is domestic. And they really went at it, and I kind of shrunk in my chair. There I am with these two people. The president was not amused. He looked at them and said, you guys cannot seem to work this out. Turned to Colin Powell and said, Colin, you take it over. So for those of you who are wondering why PEPFAR is in the Department of State, it's for that reason. Was it going to be in USAID or was it going to be in HHS? And the president said, enough of this fighting. Colin, you take it over. And he then announced the president's International Mother and Child HIV Prevention Initiative. Now, the story gets a little bit more, I wouldn't say complicated, but gets more involved because central to all of this is an individual that some of you may not have heard of at the time, a fellow named Josh Bolten, who at the time was the White House Deputy Chief of Staff. He ultimately became the OMB director and then finally the White House Chief of Staff. As we were finishing this mother-to-child transmission, Mark and I felt very good. We thought this was something that was really good. But as we were leaving the White House meeting, to my great surprise, the president grabbed Josh and I and said, Tony, the mother-to-child transmission initiative is a great start, but we need to do something on a much, much broader scale, something that is truly transforming. So go work with Josh and put something together for us, and it needs to be transforming, and it needs to be accountable. Now, I got to tell you something that actually happened. I see Mark smiling. I almost fainted. I couldn't believe that he was saying, do something. And I said, like, really transforming? So I'm going to show you this because it's very personal. This is the White House. Every time you go to the White House, you walk over to 17th Street, and you go up to the Farragut North Station to get the red line back to the NIH. Somewhere on that walk, I got on my phone and I called up Mark. And I said, I don't know, Mark was out of the country or something. And I said, Mark, you can't believe it, but he's telling us to do something much, much bigger. And Mark said, like how big? And I said, I think, as big as we want to make it to be. So we need to go work on it. And then comes in some unsung heroes in all of this. People, again, that you may not have heard of. Gary Edson, who was Condi Rice's deputy. Jay Lefkowitz, who was the counsel to the president. Margaret Spellings, who was director of the Domestic Policy Council. So our job, what we had to do, was essentially put multiple versions because we weren't sure what they really wanted. So here were some of the things that we actually considered. Was it going to be a demonstration project or really a major program? We used the terminology, we're going to do a Mercedes version, an Oldsmobile version, or a Chevrolet version. And we were constantly doing different versions. How many countries? We had no idea. You know now how many countries. We didn't know if it was going to be 3 countries or 20 countries. Only countries with good relationships to the United States or any countries? What proportion of prevention versus treatment versus care? Should it be Africa or Africa and other countries? What about India? What about China? What about Russia? What was the cost? And that gets to the Mercedes versus the Chevrolet. So for a period of months, what Mark and I did was essentially do multiple different versions. And the only thing that I haven't consulted Mark on this, but the only thing I would say that I would describe what we did was a roller coaster effect. And it was like Gary Edson or Josh Bolton want this. No, it's too much money. It's too little money. It's not enough money, and back and forth. And literally, this was a daily and weekly issue. But in the meanwhile, and this is something that seems impossible, but it's true, the president and Josh Bolton said that you and Mark can tell no one what you're doing. And I said, what do you mean no one? He says, no one. Well, how about the NIH director? I work at the NIH. No. How about the people in the department? No. You're supposed to tell no one. So Mark and I were working in a situation we were doing all these things, and people were saying, what are you doing? Oh, we're not doing anything. Don't worry about it. But things started to leak out. And one of the things that leaked out was one of the real proponents of HIV was Bono, as you well know. And one day, months into what Mark and I were doing, in September the 18th, I get a phone call from Bono, who was in Chicago, and saying, Tony, I'm hearing rumors. What are you up to? Something must be big. Can you tell me anything? And I felt really badly because we had developed a good relationship with Bono, and we couldn't really tell him anything. So he said, I'd like to come and visit you. I says, well, fine, give up my office a call and we'll set something up. He says, no, tonight. So he flew in from Chicago, came and spent the evening with my wife and I and my kids in my house talking about something that I couldn't tell him about. So I was sort of dancing around the things we were doing. He got it, and he said, okay, I understand you can't say anything, but let me know how I can help. And the way I said we could help is that when whatever we do happens, please support the president, because the president was under serious criticism because this was the issue with the Iraq war, that people were really against the president at the time. Well, things were not always very smooth because this was going to cost a lot of money. And OMB doesn't like to spend money. So when the OMB people were getting wind of the fact that I and Mark were coming to the White House, they started to get suspicious, and we started to get a lot of pushback. And at the time, Mitch Daniels was the OMB director, but there was a person who was actually not a bad person, Robin Cleveland. But she really did not like me at all because she thought that every time she saw me, it was going to cost her a lot of money. Because even though she didn't know what was going on, because Mark and I were not allowed to tell anybody except the inner circle. So one of the things she said to me, and I'm paraphrasing it a bit, but it's pretty close to what she said. She said, Fauci, you are a white guy in a suit. We don't believe that you know anything about AIDS in Africa. Besides, I heard about you. You're probably just trying to get more money for NIH. And boy, that really put me down. I said, this is going to be tough. So what she said is that we want people who've actually been in the field to convince us that what you and Mark have been telling us for so long actually is real. Can this be done? Is it feasible? So get some people and bring them to Washington to be able to convince OMB that this is doable. So I figured, well, I know a bunch of people, so I called 4 people, and it was interesting. They told me, you can bring them to Washington, but you can't tell them why they're coming to Washington. And this is the truth, because the president did not want the press or the Congress to get in the way of something that he wanted to do. He wanted to get it done, and obviously it worked out best. So I got on the phone, and I had to get people to come to Washington, to the White House, literally within a 72-hour period. So I called up 4 people who came to the rescue. My dear friend Paul Farmer, Eric Gooseby, who was at the Pangea Global AIDS Foundation. I knew Eric from the time he was the AIDS coordinator in the White House. Bill Popp, who I've known for many, many years, and Peter McGenye, who was a friend of mine and of Mark's. I got them on the phone and I said, literally, you gotta come to Washington. It's really good. I can't tell you why you're coming, but you gotta come to the White House. Now, I had promised the White House that I really would not tell them at all why they were going to. Now, that's ridiculous. How can you not tell them why they're going? But I promised the president indirectly, and it was the first time and only time that I've ever told a white lie to the president of the United States. Because I said, I tell you what, before you go to the White House, the night before, let's have dinner in a quiet place in Bethesda where I can tell you what Mark and I have been doing over a period of several months. So there's a restaurant that some of you who go to Bethesda might know. It's the Trattoria Sorrento. It's a place that's very quiet, good food, but doesn't usually have a lot of people. This is the picture of it. Now, when I walked into that restaurant to scope it out, to think it would be a good place, it reminded me of something that some of you may remember. Do you remember that restaurant? Lewis's restaurant from The Godfather. It looked exactly the same. And remember the time when Michael Corleone knocked off Soloso the Turk and the police captain. Now, I always felt I wanted to be played by Al Pacino, but I didn't point the gun at Paul Farmer or Eric Gooseby or Peter McGenny. They were overwhelmingly willing to go to the White House and say, what we had put together makes absolute sense, and they think that it actually can happen. And so what happened very rapidly over a period of a few days, because this was, I think, in December that we brought them down, is that Mark and I were like on pins and needles because we did not know whether they were going to accept it or not. And we were really getting very anxious. Are they just going to throw it out, or is it going to be announced? The way things get done in Washington, you announce it in the State of the Union address, and we were not sure that that was going to happen until one day I got a call from Kristen Silverberg, again, someone who you probably never heard of, who said that Michael Gerson, who was the speechwriter at the time, wanted me to come down to the White House to help frame words that were completely accurate, the words that we worked with, and it was mentioned in the introduction, the largest, most important program for a single disease ever. What would we call it? Should it be an emergency plan? Should it just be a regular plan? We put things together, and the phrase went into it. But one last request was, we want you to bring back Peter McGenye. And I said, why do you want to bring back Peter McGenye? Because we want him to sit in the First Lady's box in the Congress when the president did the State of the Union address. Here's a picture of Peter, who came from Uganda to that, and that's when the announcement was made. And on January 28th, the president made the announcement announcing the president's emergency plan for AIDS. And you remember at the time, he accepted the Mercedes version and not the Chevrolet version, $15 billion over 5 years to prevent 7 million new infections, to treat 2 million HIV-infected people, and to care for 10 million HIV-infected people, including vulnerable orphans. And as things turned out, you all remember that the global AIDS coordinators started off with Randy Tobias. It was very interesting. They were talking about, did I want to be the head of PEPFAR, but I'd have to give up NIAID, which I didn't want to do. They asked Randy to do it, but Randy was a businessman. So that's when they brought Mark in, and to my great dismay, but to the great benefit of the country, Mark moved over and went to PEPFAR, and soon to then become the director and the ambassador for PEPFAR, followed by Eric, followed by currently with Debbie. Well, we had a very interesting experience. I wrote about this in the New England Journal of Medicine, about the 15 years and counting, and we had a wonderful time in May 9th of 2018 when President Bush invited a number of people, including Mark and I, to go to Dallas to celebrate the 15 years of PEPFAR. And this is just a picture. That's Barbara Bush, the president's daughter, who is moderating a panel. That's Paul Farmer and I, and actually Lindsey Graham. Mark was on the other panel. We had a wonderful time, and what we talked about is what you all are going to be talking about over the next several hours today, is about what happened from that time on and the extraordinary historic event that related to the fact that we had a president of the United States who showed spectacular leadership in doing something that really is truly historic. And I think we all need to remember that although we were the instruments of this, this was the president of the United States who did this. Thank you.
Can you hear us okay? Okay, wonderful. So, wow, thank you for that. That is an amazing story. And I think for anyone who has heard you many times over, there's so many little pieces you still bring to the table that are amazing. Bono? Wow. I'm not quite sure what I would say if I got a call from Bono. So we wanted to just have a little bit of a conversation, and then we'll open it up for the audience. We're going to run just a smidge over our time, but we'll make it up later, just so we have enough time, because I know a lot of people want to ask some questions. But I thought I might kick it off with a few. So I think the thing I was really struck by, what you said in your slides, was the comment that President Bush made about morality. And what are our moral obligations as a community? And I wondered if you could kind of help us frame that both in your decisions around what you chose to give us the Mercedes version of PEPFAR, and how do you think that's leading us forward as we move through this epidemic?
Well, you know, it really is fundamental to the question, do we feel as a nation, and I do, and the president certainly did, that we do have a moral obligation, that we have responsibility. We don't live in a vacuum. We can't separate ourselves from our fellow man throughout the world. And it was just absolutely extraordinary that the president of the United States, the most powerful person in the world, explicitly made that statement and acted on that statement. And I feel that we have that beyond HIV/AIDS. And I think that's the reason why we are in the Democratic Republic of the Congo with Ebola, why we were in South America and the Caribbean with Zika, because we are a rich nation and we have responsibilities. Now, there are some people who don't agree with that. And I mean, obviously, you know, you've got to, you know, you can't get everyone to agree with you, but I really do think that's a fundamental pillar of what the United States of America is.
Yeah. And I'm thinking a lot about, you know, for a lot of people in this room who have been working on the epidemic alongside you since the early days, and speaking to that piece around morality and obligation, this is perhaps a unique epidemic, as far as I know, in terms of having both the science and activists working side by side. And I wondered, how did you were there right from the beginning, and anyone who has seen any press from the early days, you know, Dr. Fauci was right in there in the beginning working with both activists and scientists. How did you thread the needle to really combine these two worlds and bring these two groups together?
Well, you know, it became apparent to me, and I had not experienced that before, because the kinds of diseases and things that I had been involved with really didn't have that community connection at all. It was a novel thing for me. In the very beginning, the activists were making very good points. And the scientific community is much different than it is today, was really quite rigid. The classic scientific community and the regulatory community, it was really, you know, we love you, but we know better than you about how things should be done. And that was the attitude that was taken in the early years, particularly when we were doing clinical trials, when we didn't really have good medications. And when they were not listened to, they became very iconoclastic. I found myself caught in a very interesting situation that was difficult in the beginning, but it turned out to be wonderful after a while, is that since I was one of the people that was visible as the director of NIAID, I was in the press, I was on TV, I was talking about it, I was the face of the federal government. So they needed somebody to shoot at. So they said, there's the guy we're going to shoot at. So they started to attack. And it got me even more to say, well, rather than shy away, because the scientific community ran for the hills. The people in my staff, Mark will tell you, they just disappeared. They say, what do you want to deal with these crazy people who would be coming on the NIH campus? So I made a decision that I would try to put myself in their shoes. What would I do if I were either at high risk or were infected? Would I be sitting down waiting for some bureaucrats in Washington who tell me it's going to take 7 years to do something when the life expectancy is 1 year? It didn't make any sense. So I started to listen to them. And what they were saying, if you put aside the confrontation, the theatrics of it, what they were saying was making absolute perfect sense. Our clinical trial apparatus were not taking into account the fact that you didn't have a drug and you were withholding it from people who were going to die if you withheld it from them. But we had to be the pristine, this is the way, your BUN has to be below this and your crit needs to be at this level, otherwise you're not going to get into a trial. So we became much more flexible. Mm-hmm. So that's really how it started, was to just listen to them, and they really taught us a lot. Right?
It's phenomenal. I mean, I guess the thing that I wonder now, if you can kind of look in that crystal ball, right? Because some people are saying what got us to here is not what's going to get us to there. And we've had this tremendous uptick and surge in getting people on treatment. Right. And now we have this group where there's still these deep challenges, stigma, discrimination, barriers in access to care. If you can use that crystal ball and all that you've learned over these last decades, what do you think lies in our future?
Well, if the future you're referring to, give a specific example, otherwise the answer will get too diffuse. If the future is how, we have a so-called plan, which is a good plan, to end the epidemic as we know it in the United States, to go down by 75% by 5 years and 90% by 10 years. One of the difficulties that we're facing in the United States is that 50% of the infections are in a very, very restricted geographic and demographic group. Within that demographic group are predominantly African American, men who have sex with men, particularly those who live in certain rural areas in the South. And the absolute major stumbling block of getting access to them and getting them on treatment if they're infected or PrEP if they're at risk is stigma. Something that you don't appreciate in the ivory tower of the NIH and of Harvard, but they are totally stigmatized. It becomes almost impossible for them to openly go out and try and get tested and be on care. So it's going to have to be engagement at the community level. We're going to have to get people at the community level, faith-based organizations, the clergy, the community leaders, to go out and try and access those individuals. Otherwise, the plan is going to remain a plan, and it's not going to work.
Yeah.
Yeah.
I'm struck by, and thank you for bringing up also the US epidemic, because we have many people in this room who are thinking a lot about that. You've talked about the narrative of HIV with 5 different presidents. 6. 6 different presidents. How do you manage to keep these issues at the forefront when some might argue, well, it's maybe not as big as cancer in the US now? How is this still remaining such a critical issue here?
Well, I mean, the fact that it's 5 separate presidents, they're 5 entirely different people with different approaches towards things. So you have to just keep the science and the public health and get away from any ideology at all. And I think that's the reason that I've survived, because I'm now known very clearly by everybody to be completely apolitical. No ideology, it's all public health, it's all science. It doesn't matter who you are, whether you're arch conservative or whether you're entirely liberal, it doesn't make any difference. The thing is persistence. You really have to keep pushing. In Washington, there's no such a thing as trying something once and it works. It doesn't. Whether it's budget, whether it's, I mean, if you just look at what I was talking about, PEPFAR. Mark and I were consumed for like 8 months of almost every day. We could have said, well, we tried and that was it. And it goes well beyond. PEPFAR is the big giant about that. But even the little things, you have to continue to keep it on the radar screen. Like right now, the situation, you're right, there's complacency with HIV because we have such excellent drugs. But if you look at the number of new infections and you look at what the economic cost is going to be, what the cost in health is going to be, you got to just keep putting that on people's radar screen and never let it off. You cannot do it in a one-shot basis.
I think that all of us, collectively owe so much to PEPFAR and to the NIH and to you and all of the colleagues that you've gathered together here today to continue to push on these issues. I'd love to open it up to people who may want to have some questions. We can keep on going, but I feel like there may be a few people in the audience who may want to step forward for this wonderful moment and consider asking Dr. Fauci a little bit about his narrative. Dr. Friedberg will open it.
A lot of
Thank
people
you.
sitting down. I'm Ken Friedberg from Mass General. I'm going to try and get this question mark within 20 words. Completely unrelated to PEPFAR, there were 70,000 substance use disorder deaths, overdoses in the United States last year, more than that 1995 peak that you showed. If this were an infectious disease, you would be completely focused and you would take everything you've learned in the past 15 years to deal with that. So what can you teach all of us, and how can we take the activism, the science, and shift it towards that epidemic as we continue the work on HIV?
Yeah, I think what is it going to need is much more activism than I'm seeing. If you look at, I think it was $500 million that the president's budget went into for opioid abuse out of the NIH, just the NIH alone, not other. That's fine that we put that money in, but what I'm not seeing is that kind of grassroots community activism from the grassroots up. There's a concern about it, there's resources put into it, but there isn't, I guess, that outrage of exactly what you said, that there are 70,000 deaths, and a lot of people are just blowing that off as well. It's opioid use, let's move on to the next thing. There's not the community outrage that I would expect to see. I'm an infectious disease person. I look at that and I say, wow, I don't want to get out of my lane and do somebody else's job, but I would maybe be a little bit more active about this. Right.
Bruce Walker from the Reagan Institute and the Harvard University CFAR. Tony, what do you see as, there's been just such a phenomenal success thus far in terms of dealing with an epidemic that we as clinicians in the beginning saw as a death sentence. What do you see as the threats in the future to sustaining and actually extending the successes that have been made?
What I would hope, and that's what I and others talk about a fair amount, is to use the HIV/AIDS experience as a model of what can be done if you put resources, your best people, and a enduring effort into something. And I refer to, global health threats. Influenza is a very serious threat to everyone. Tuberculosis is still a major, major problem. Malaria, we've become complacent about malaria. Malaria is just, if you look historically, and I've been arguing that we can, if we put the same approach and resources into TB, malaria, diarrheal diseases, we could do with what we've done with HIV/AIDS. In fact, the PEPFAR and the Global Fund model the infrastructure that's built up is already spilling over into utilization in other areas, which I'm sure we're going to hear about a little bit later on in the conference. So I would think that putting resources in does pay off. It really does. I mean, if you look at HIV/AIDS, some people say this is disproportionate, and in some respects, they are correct. 10% of the NIH budget, of the entire budget, is on HIV/AIDS. 1/3 of my institute's budget is HIV/AIDS. And the reason for that is the advocacy that went into putting resources into that. If we did it for AIDS, why not for malaria? Why not for tuberculosis? There's no reason not to. There's absolutely no reason not to. So my answer to your question is, let's just do exactly the same thing, Bruce. Right?
Hi, I'm Sydney Rosen from Boston University. During the time that PEPFAR was being designed, as I recall, there was a great deal of concern, or at least rhetoric, around HIV as a global security hazard, that countries were going to fall apart. And the U.S. had to invest because we had to maintain, it was a U.S. security issue. I'm curious about how that played out and whether was it all just rhetoric intended to get us to move on things, or were there people who truly believed that HIV would undo countries and we'd have failed states and a security threat?
No, it was real. It was real, actually. And Colin Powell, in my discussions with him, actually made that a major issue. I mean, not the only issue, but he felt very strongly, because as the Secretary of State, he was examining, particularly, we were looking at the militaries of different sub-Saharan African countries. The prevalence of infection among them was pointing to the fact that they would collapse if they did not wind up getting treatment. I mean, 40 to 45% of some of the militaries in different countries. So it was a real thing. It wasn't the predominant driving force, but it contributed to it, no doubt. The national security issue was important.
I'm wondering if I can pick up on that point where, you know, you're at the beginning of PEPFAR, and you're working with countries who have very different responses to the HIV epidemic. And I mean, a lot of people here have thought about, as I know you have, what was happening in South Africa, for example. How did you thread the needle in those circumstances where there really was a range of responses to this epidemic?
It was complicated. There was a lot of discussion of what the total scope of what you wanted to get in. So the way we modeled it was, and there was a lot of modeling done. We had a person in my office who was one of our budget people who liked these models, so worked with Mark and I and put models together with formulas that I still don't understand. But it worked out. We were trying to get at least 50% of the infected people in the world under the umbrella of PEPFAR. And we wanted to do countries that had a system that we thought could implement such a program, who were not just failed states that it would be throwing money away. Because one of the important issues that Josh Bolton and Gary Edson and the people who were working daily with Mark and I were saying that the president was very adamant. He wanted it to be transformational, but he wanted it to be accountable. He did not like the idea of giving money and having money go down the drain. He was very, very sensitive about that, which was one of the reasons why people would ask the question, I'm surprised it didn't come up, is we were having the beginnings of a global fund. Why did you need PEPFAR? And the president had respect for the global fund, but he was much more a bilateral person than he was a multilateral person.
Ken Mayer, Fenway Health, and the medical school and School of Public Health here. So it's unlikely that the pot is going to be increasing dramatically over the next few years. And it could be argued that one of the signal successes after PEPFAR got established was the advent of generic drugs, which really decreased the costs and therefore allowed for greater expansion of treatment access. What innovations do you see going forward that will allow further expansion and intensification of the program? Is cheaper diagnostics, or Are there other things that you think we'll be able to allow to expand, since there still are many millions of people still who need to medication and need stable monitoring?
Yeah, you know, that's not an easy question to answer, Ken, because certainly getting the cost of drugs to as low as you possibly can, one of the issues, and again, I'm sure that Mark and Deb are going to be able to address that much better than I, because they're in the middle of it right now, is the issue of PrEP. I mean, the accessibility of PrEP in certain countries that are just barely getting the people who are infected on treatment is something that we really need to address, and that's going to be a problem, and you're going to hear about that later in the meeting.
So we'll take Jessica's question and then we'll wrap up for time.
Thank you. Jessica Haber from Mass General Hospital. So I mean, this has been a fantastic discussion, and I think, Ingrid, you raised a very good point about how the future of how we address the epidemic may be very different than the past. And a lot of the innovation, I think, that may change how we address the epidemic will come from the countries where we're working. I wonder if you could talk a little bit, as you know, in your role at NIH, how we can best engage the African scientists or the Haitian scientists or wherever we're working to bring in their innovation in ways that I think is probably underutilized now.
Yeah, I mean, you're asking a question that's core to the future, and that is that we started off with the President's emergency plan for AIDS relief, and right now, what it really is merging into is having more and more countries who've gotten the jump start from PEPFAR to essentially make the commitment that HIV and their approach to HIV, together with all of the things surrounding HIV, have to be a very important part of their national plan. And it has to be that. I mean, it wasn't that way in the beginning because they couldn't, but that's why you're seeing sort of the kind of, not changing, but evolving. PEPFAR is an evolving, and again, I don't want to take anybody's thunder away after me, but the PEPFAR program is not what it is, not now what it was back then, because the purpose of what it had to do then was essentially start off with nothing and get it going. Right.
Well, I really want to thank Dr. Fauci on behalf of all of us here and on behalf of everyone who's been impacted by PEPFAR. We cannot thank you enough for your vision and for continuing to keep HIV at the forefront of the government and research agenda, and for all of us who are involved in this epidemic. Thank you so much.